Zakula from the Minnesota Dental Association. Please turn on your microphone, your video, and begin your presentation.
Good afternoon. My name is Michael Zakula. I practiced orthodontics and hibbing for 35 years, served as president of the Minnesota Dental Association, and am presently involved in rural dental programs, loan forgiveness initiatives, and serve on the admissions committee at the School of Dentistry. Thank you, Chair Benson, Senator Draheim, and committee members for allowing me to testify in favor of Senate File 1059. As a former member of the Rural Health Advisory Committee and chair of its work group that compiled the report, Strengthening Oral Health System in Rural Minnesota, I strongly believe that a dentist is an essential member of this committee. The interrelatedness of oral health and overall well-being is indisputable. A rural health system that does not routinely include dentistry in its decision and policy-making process will never achieve optimal level of health for its patients. In rural communities across the state, dental clinics play a critical role in providing care to these communities. A dentist practicing in a rural community can provide input and advice on the significant barriers to care that are being experienced. These not only include access to care, but also workforce shortages. While Minnesota has some of the very best oral health outcomes in the country, there are significant disparities between care results in urban versus rural parts of the state. Geography should not determine a resident's access to quality care. Dentists can provide a comprehensive input in regards to the development of holistic health policy decisions. They are the primary director of dental care and all members of the dental team, therefore bearing the ultimate responsibility for a patient's dental health. The interrelationship between dental health and overall health is a strong component of their core education. The Rural Health Advisory Committee's mission is to advise state leaders on rural health issues. This proposal of adding a dentist as a committee member will certainly help facilitate interprofessional communication and improve the overall quality of its recommendations. Thank you.
We can't hear you, Chair.
Sorry, microphone. For the record, we do have a quorum. Senator Draheim, any further information you would like to share with the committee on this bill?
You know, I think we all know how important dentistry is to our health system. It's the one place that most of us go to at least once or twice a year. And there is a shortage of dentists in rural Minnesota. I think this is just a natural expansion of that committee. So with that, I stand for questions.
Thank you, Senator Draheim. Questions from members? Okay, seeing none, I'll ask members to turn on their video, turn on their microphone. Actually, members, we do not need to do that. Senator Draheim, though we have not moved your bill, we'll be laying this over for inclusion. So Senator Draheim moves that Senate File 1059 be laid over for possible inclusion in our HHS omnibus bill. Thank you, Senator Draheim.
Thank you.
Next on our agenda, Senator Senjum, Senate File 701. And is Senator Senjum available? Okay. Members, Senator Senjum is not on the call yet. We will watch for him. We do have some other business that we can take care of. I'll be moving a vehicle bill. Members, at the bottom of your pile is Senate File 2247. And I am moving to the bottom of my pile. Members, it is appropriation for the Emergency Medical Services Board. So I'll move Senate File 2247. I am going to strike the appropriations on line 1.7. So it'll be a blank appropriation. So we're going to delete $1,888,000 the beginning of the sentence and the second $188 million as well. Members, any questions as to the vehicle bill? Okay. Seeing none, I'm going to ask members to unmute, turn on their video. And members, all those in favor of Senate File 2247 as amended, be recommended to pass and move to the Committee on Finance, say aye.
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 Any opposed? Thank you, members. We have our finance vehicle on its way. Is Senator Senjum available? Senator Draheim, I believe you have a bill in another committee, but if you are ready, we could move Senate File 2110. Okay, Senator Draheim isn't ready to move his bill either. Senator, I believe Senator Senjum did join us. My apologies, members. I do not see Senator Senjum. Okay.
Madam Chair?
Senator Senjum, welcome to the committee. Is your video on?
Yes.
Thank you. Now I see you, Senator Senjum. Welcome to committee. Senator Rosen moves Senate File 701. Senator Senjum, would you please begin your presentation?
Sure. Thank you, Madam Chair and members. Senate File 701 is a bill that's been before you a couple of other times in recent years. Hope is, of course, we can get across the line right now. The bill is to add the dental benefit back to the list of covered services for adults on Medicaid that has to do with periodontal disease. That was taken out of the dental benefit, if you will, back in 2009 during tough times where a lot of things had to be cut. It's never come back in the bill. There's obviously a number of individuals through time that that suffer from periodontitis, I believe it is, and the gum disease. It's part and parcel of the health of the mouth and teeth and decay and things like that. But we all know what a toothache is, Madam Chairman, and maybe that's all I need to say today. There's a lot of people out there that are suffering, don't have the coverage, if you will, to accommodate that. This bill would do that. There's a fiscal note. I believe it's around $2 million the first year and $4 million for 23 and 24. That is the essence of the bill. I want to have Dr. Nelson from the Community Dental Clinic maybe pick it up from here and carry it forward.
Thank you. Dr. Nelson, please state your name for the record and proceed.
Madam Chair and members of the committee, for the record, my name is Dr. Siobhan Nelson. I'm a dentist and the dental director at Community Dental Care, the largest critical access dental provider in Minnesota. I thank you for letting me testify today on why periodontal coverage should be added back to the Medicaid benefit set for adults. This proposal makes sense both from a healthcare perspective and from a financial one. Community Dental Care serves over 50,000 unique patients each year with clinics in Rochester, St. Paul, Maplewood, and Robbinsdale. Today, I'm speaking on behalf of Dental Access Partners, which besides our clinic system includes Apple Tree Dental and HCMC's dental department. Together, our three critical access dental organizations serve patients of all ages in nearly every Minnesota county, and more than 85% of these patients are enrolled in Minnesota healthcare programs. We reach people facing barriers to care by delivering dental services at our clinics at over 175 community sites, including Head Start centers, schools, nursing homes, and other locations. In fact, recent data shows the dental access partners provided almost 15% of all Minnesota healthcare program dental services statewide. Given the broad bipartisan support and growing understanding of why restoring periodontal disease is so important, I'm going to make 4 key points and then would welcome any questions. The first is that medical assistance currently covers only one of the 2 main diseases in the mouth. Tooth decay is a bacterial infection of the enamel and the dentin of a tooth, and this treatment is covered by Medicaid. The second, periodontal disease, is bacteria infection infecting the gums and bones supporting the teeth, and treatment of this is not a covered service. This bill simply corrects that problem by adding back a very basic essential benefit for the simplest and most effective treatment for periodontal disease. So my second point is that what is best for the health and well-being of our patients. Periodontal disease is the leading cause of tooth loss in adults, which has long-term impact both on our patients' quality of life and it contributes to costly care. Numerous studies have shown that untreated oral infections not only destroy teeth and the surrounding bone, but they can also have a wide-ranging negative impacts for the overall health, which leads to higher medical costs overall for these patients with a number of chronic diseases, including diabetes and heart disease. Third, not providing a benefit for periodontal care for Minnesota healthcare programs patients has a tremendous negative impact on dental education and training of dentists and hygienists that are learning these procedures and how to treat these conditions at the University of Minnesota Dental School and other educational institutes. And for my final point I want to make is an economic one. As you've heard Senator Senjem, numerous economic analysis show that patients with common chronic conditions who receive periodontal services have significantly lower overall medical cost. For heart disease, the saving in one study was $1,000 per patient per year. For a patient with cardiovascular disease or stroke, that savings was $5,000 a year per patient. For a patient with diabetes, that savings was around $2,800 per year. And according to the American Diabetes Association, approximately 467,000 people in Minnesota, which is about 10.5% of the adult population, have diabetes or pre-diabetes, which costs an estimated $4.4 billion for Minnesota each year. If we are able to do anything to treat an underlying disease that can lower this cost, to me it makes sense to do so. As a dentist who treats highly medically complex patients virtually every day, I witnessed the fact that the effect and the cost of poor oral health on their overall health. This benefit is so needed by our patients. And in closing, I encourage you to support Senate File 701. Thank you again for the opportunity to testify, and I welcome any questions.
Thank you. And next, members, to the fiscal note. Mr. Albrecht, if you could give us the highlights of the fiscal note.
Good afternoon, Madam Chair.
Mr. Albrecht, the fiscal note, and high-level numbers. We've got Healthcare Access Fund and General Fund impacts. If you could walk us through where those are driven from.
I will. So as Senator Senjem mentioned, the total numbers are 2.1 million in the first biennium and 4.4 million in the second biennium. And you can see the total amount for both the general fund, we don't have totals by fund at this level, but it looks like it's about 1.5 million. 1.6 million for the biennium and a little over $500,000.
Mr. Albrecht, we're having a little trouble hearing you.
That's because my voice is trailing off. Okay, Madam Chair, on page 2 are the funds, again, the amounts by fund, and then in the middle of page 2 are the underlying assumptions for the totals. And the important point there, as Senator Senjum mentioned, is that these used to be covered services in MA, and that they rely on those proportions to come up with the calculations here. So in the second paragraph, the second sentence, there's a range of 0.2% to 1.1% in MA fee-for-service that would be receiving the procedures authorized in this bill. The last sentence, or the last paragraph there, talks about the effective date of July of 2021 in fee-for-service and January of 22 for the managed care plans. The expenditure and revenue formula tables go through the individual populations in MA, and show you the average monthly cost and the total cost for each population, including the assumed, phase-in over time in the first year. For each major eligibility category in MA and in Minnesota Care, that's most page 3 and page 4. And then on page 5 is the summary by fund, which does show the amounts for each MA eligibility category. For those who aren't familiar, ED is elderly and disabled, AD is adults without children, and FC is families with children. And then the healthcare access fund amount obviously is Minnesota.
Thank you. Members, questions to the fiscal note? I will just comment that I keep hearing that if we do things like cover periodontal disease, it makes managing heart disease more successful in this population, reduces the risk of diabetes. I'm not asking for dynamic scoring, but some of these people with periodontal disease, we know, end up in the hospital because there's no other path for them to get their problems resolved. And so we're not even seeing a reduction in hospitalization in this proposal. So I'm just, again, voicing frustration with what are good ideas not being documented as being good ideas in our fiscal note process. Senator Abler, and we are 2 questions from committee members. Senator Abler.
I'm just going to pile on your comment there, Madam Chair. This is ridiculous that there's no way to consider the secondary immediate effects of an action upon these individuals. We have some cases that are that review process with MMB. I forget what that's called now, but I just want to pile on. We are just serving the public and frankly the taxpayers that are paying for this, but the public we're trying to serve, we're actually just serving them by not being able to do some of this stuff that is going to make money by saving, and not to mention that they might not die from heart disease. So I'll leave it go there. Thanks, Madam Chair.
Thank you, Mr. Chair. I'm sorry, Senator Abler. There is a document from Avalere Health. Now, this is from 2016, but it talked about some of the interactivity for Medicare Part B benefits for particular conditions. So members, as we consider the impact that this might have on impacted populations, let's keep some of these studies in mind. I'll be checking to see if it's peer reviewed and met a good academic standard, and push back on the department to say if there is documentation that there is benefit, then we should include that in our analysis. Members, questions to the bill? Okay, I'm checking the room, seeing no questions. Senator Senjum, thank you very much for your bill. Senator Rosen, Senate File 701 will be laid over for possible inclusion in our omnibus budget bill. And members, we're going to adjust our order. We're going to move to Senator Wickland's Senate File 981.
Thank you. Thank you, Madam Chair. I'm happy to be the author of Senate File 981. There is an amendment that includes the revisions that MDH will be talking, it includes the language, excuse me, for the proposed revisions to the governor's budget. And would you like to adopt that first, or do you want them to go through them?
Senator Wickland? Let's see, I just want to verify because I'd been told there was a rather large amendment. We're talking about the A21. Is that correct, Senator Wickland?
Yes, that's correct.
Thank you. Senator Wickland will move the changes first, and then we'll have MDH walk through the language as amended.
Thank you.
So, members, Senator Wickland moves the A21. Please turn on your video and your microphone. All those in favor say aye.
Aye.
Any opposed? Thank you, Senator Wickland. To Senate File 981 as amended.
Thank you, Madam Chair, and I will turn it over to, I believe that Joshua Bunker is going to go through a presentation with us on the changes.
Mr. Bunker, welcome to committee. Please turn on your video.
Good afternoon, Madam Chair and members. My name is Joshua Bunker. I'm the Chief Financial Officer for the Department of Health. I apologize that today, I understood earlier we were going to be presenting the items that were reflected in the governor's revised budget and not moving through the bill. I apologize for that. We have a small handful of items, and we certainly can follow up with exactly how they align with now the amended bill. They are few in number, and I believe will be easy to follow once the bill comes up. May I ask Lisa to present the slides at this time? Thank you. We wanted just to begin by refreshing the members on some of the impact to the pandemic funding that we are anticipating with the American Rescue Plan. In the last day, we are now beginning to receive updated information from our earlier estimates. And so the American Rescue Plan amount that is shown in purple on the bar chart in fiscal year 22 and 23, we are presenting that as 0.85 billion. That now is approximately 0.3 billion, as the ratio of distribution is different than the originally supposed at the time. Next slide will show the details of what we understand from that bill at this moment. You see 8 different funding areas in the rescue plan, beginning at the top with WIC funding. Then there is evidence-based home visiting program, the next award. Again, these are estimated for $3.4 million. Clean air, safe drinking water for $1 million. Youth suicide prevention, early intervention for 0.3. Health Service Corps for 1.8. The ELC Enhancing Detection Award. This is the award that we believed earlier was going to be larger. We have seen for the first time that these monies were shown by federal HHS, and now we see that at $169 million. Second from the bottom is additional funding for vaccine efforts. We do have a $51 million grant that we are now working on that has been reviewed and approved. This was our estimated amount, given the reduction in the testing award immediately above. We are not sure if we will reach this $85 million amount. And then the item at the bottom of the page is a specific grant funding category for genomic sequencing and surveillance. Again, our initial estimate was in the $17 million range, and we will see once we receive final notice of funding on these amounts. Next slide, please.
Pardon me, Mr. Bunker,
Madam Chair.
so we have not received final notice on these dollar amounts?
Madam Chair, that is correct. The way in which we were arriving at our earlier estimates was comparing the amount we received during the last funding round, which happened in December, and applying a proportional population-based percentage against the amount that we saw in the federal bill, since the bill itself was not divided out to a low enough level in those federal agencies at the time. And so only now we are receiving day by day some updates. The only numbers on this page that we have seen as clear is the top amount for cash vouchers on WIC and the $169.8 million in the ELC that is the third from the bottom.
And Mr. Bunker, just to clarify, will these be traveling in the governor's budget? Will they be traveling on a spreadsheet in the House, or will you be using the LAC process?
Madam Chair and members, these were submitted, I believe about a week ago in the latest LAC request that was for the total in the neighborhood of $2.6 billion for those areas that were understood. These estimated amounts were included at that time.
And so, Mr. Bunker, when you do get updated amounts, we'll need a submission to the LAC for those amounts. And I believe I've put in some requests because this is not, members, and for the members of the public, this is not sufficient disclosure for the LAC process. And so that's why I'm drawing this out now, so the public can understand that we need more information for the LAC. But if this language were traveling in the House, it would be easy for us to access a description of what these of what these programs would be funding. So thank you, Mr. Bunker. Please continue.
Thank you, Madam Chair. Next slide, please. The revised items that are now in the updated are shown in the lighter blue on the page. So you see the addition of a tobacco and vaping prevention and cessation item noted at just over $8 million per year. Those amounts are being shown in brackets as they would be presented as a net zero to the fund, offset by the tobacco settlement itself that just passed. I believe it was on the 15th of this month. It was just agreed to. In the reductions, you note that the right sizing of home visiting grants was updated to a one-time only for this upcoming biennium. Similar for the fetal alcohol syndrome grants as a one-time only. The eHealth Advisory Initiative reduction would continue as an ongoing reduction. And then the Merck formula grants would be removed. They were initially submitted as a $1 million reduction per year. That has been removed in the revised. And then finally, there is a proposed shift of the prescription drug transparency item, where the appropriation arrived at the agency in 2020, even though the language first passed in fiscal year 19. This is acknowledging that we have been slow in our ability to address this due to internal agency resources being dedicated to the COVID response. And so what this will do is propose a modification to the laws of 2019, reducing those amounts by $395,000, and then bringing only $210,000 forward into the bill for fiscal 22 only. Next slide, please.
Mr. Bunker, could you review, please, the prescription drug price transparency? Senator Rosen has been on our committee for years. I just would like some clarification as to what's causing this slowdown.
Madam Chair and members, the legislature appropriated monies for this act in 2019, but we were asked not to spend the money until the legislature acted to codify the act into statute, and that was in 2020. And while we were preparing to ramp up for those activities, then COVID hit and agency resources were diverted to COVID activities. So due to this disruption, we are looking to shift a portion of the resources that we would have used to continue these activities from this present fiscal year in fiscal year 21 into fiscal 22 to complete those startup activities in that energy.
Mr. Bunker, I would like to check with Senator Rosen to see if she has any questions or concerns on this provision.
Thank you, Madam Chair. I just wanted to let you know. I wanted to let you know that they did apprise me of this, and Representative Morrison. Thank you.
Thank you. Please continue, Mr. Bunker.
Thank you, Madam Chair. Next slide, please. The only proposed revised change in the State Government Special Revenue Fund then is a net zero change to vital records electronic transaction fees, and that would be enabling a third party to handle transactions which now happen in person in various locations where people are requesting vital records. And so it is an online enablement, e-business enablement, and there would be a nominal fee associated with the transactions as they would move through this third party. I believe I've heard in the neighborhood of $2 per transaction, something like that when requesting vital records. And Madam Chair, that completes the revised items from the governor's budget.
Okay.
Any questions?
Thank you. Members, questions? And obviously, this was not a full walkthrough of Senator Wickland's bill, but we did want to make sure that the language was available to pick up. So questions from members as to Mr. Bunker's presentation? Okay, seeing none. Let me see, we do have a testifier, Amanda Jansen from Clearway, Minnesota.
Yes, thank you, Madam Chair and committee members. My name is Amanda Jansen, and I'm Director of Public Policy at Clearway, Minnesota. I'm here on behalf of Minnesotans for Smoke-Free Generation, a coalition of more than 60 organizations committed to ending youth tobacco addiction. We support the governor's recommendations to invest more resources in tobacco prevention and treatment. This proposal mirrors language introduced this year by Senator Miller, which is found in Senate File 684 and in Senate File 1484. Reducing tobacco's harm is a public health success story. Today, we all enjoy smoke-free air, and tens of thousands of Minnesotans have broken their addiction to cigarettes. Our collective work has saved thousands of lives, prevented thousands of cancers, and saved Minnesota more than $5 billion. If Minnesota continues funding tobacco prevention at current levels or higher, we can save another 14,000 lives and $10 billion in healthcare costs. Clearway, Minnesota, which has provided the majority of tobacco prevention and treatment funding for 20 years, will sunset this year. Unfortunately, major health threats remain. In Minnesota, 1 in 5 high schoolers is vaping e-cigarettes, and more than 70% of youth e-cigarette users are showing signs of nicotine dependence. We must do more to reverse these trends. Last year, Minnesota collected about $760 million in tobacco revenues, but only spent about 1% of that on prevention and treatment. We have a prime opportunity to change that. Like was already discussed, just last week, 2 major tobacco companies reached a settlement to pay Minnesota $81 million in unpaid tobacco settlement fees now, and at least $10 million a year moving forward. The legislature should invest a portion of these fees in prevention and treatment. We're grateful to the leaders in the Senate, the House, and the administration for working towards solutions to Minnesota's tobacco prevention shortfall this year. Thank you.
Members, questions to this provision? Watching for hands. Right. Seeing none, thank you, Senator Wickland, for bringing Senate File 981. There are some concerns about provisions. And so I'll be working with the Department of Health to see which they need for compliance. We will be having a policy article, and that will roll out with our budget next week. And with that, members, we are moving on. Senate File 981 is laid over for possible inclusion. Next, we'll move to Senate File 982. Again, Senator Wiklund, Human Services Miscellaneous Provisions. And again, Senator Wiklund, there was an amendment to this bill. I believe there was also a late amendment. Could you walk us through which amendment we should be looking at?
Thank you, Madam Chair, for hearing Senate File 982. And I would like to defer to Mr. Monahan if he's available. I know that the second amendment, I was notified about it just a couple hours ago, and I'm not sure if it's if everything is in one amendment now, or if we need to adopt both of them. And maybe if Mr. Monahan could clarify that, I'd appreciate it.
Mr. Monahan.
Madam Chair, members, the reviser made some last-minute changes to the amendment and sent a second version of it. It's posted in the hearing notice. It's the one that's coded A21-0128- and a whole long string of numbers. And then it says final at the end. It arrived just moments before committee, and it may not have been printed, but it is posted.
Okay. Mr. Monahan, we did not print copies, but members can go to the committee site and review the amendment. Senator Wiklund, how would you like to proceed with the amendment? Do you want to adopt it and then have Commissioner Harpsted and Mr. Anderson do a walkthrough as amended?
Yes, Madam Chair, I think that would be best to adopt it, and then we can go to the testimony. Thank you.
Thank you. Okay, members, we are going to move the, Mr. Monahan, remind me, the A21 dash.
0128 let's just abbreviate 2723, etc.
2723. Mr. Monahan, we simply need enough information to differentiate it from the other amendment. So Senator Wiklund moves the A21-0128-273. All those in favor say aye. Aye.
Aye.
Any opposed? Thank you. Senator Wiklund, Senate File 982 as adopted, or as amended. Let's begin our walkthrough. Commissioner Harpsted, welcome to committee.
Thank you very much. Good afternoon, Chair Benson and members of the committee. Thank you for the opportunity to share the proposals from Governor Walz's supplemental budget that affect human services. Today, you'll also be hearing from two of our assistant commissioners who will walk through the proposals from their areas that are new or have changed since we last presented to the committee. The governor's supplemental budget proposals for human services build on the priorities laid out in January. This includes targeted investments that support the agency's mission, measures that reinforce process controls, and efforts to help Minnesota recover from COVID. We don't want to just get back to normal. We aim to get back to better. While we're encouraged by recent progress fighting COVID, there's no question the burden of the pandemic and its economic fallout have been significant for low-income Minnesotans. Consider that over the past 12 months, the Minnesota Family Investment Program cases are up 18%, or nearly 5,000 families. Minnesota healthcare programs, Medicaid and Minnesota Care, have seen enrollment up 11%, or 75,866 enrollees. And Supplemental Nutrition Assistance Program, also known as SNAP, enrollment is up 11%, or 21,646 families and individuals who need assistance. In the face of this need, we're grateful for the improved economic outlook for the state. This has allowed us to remove some of the more difficult cuts we made in January and make some key investments to help ensure an equitable recovery, all while making sure we are crossing our T's and dotting our I's. Our proposals are based in part on listening we've been doing in the communities we serve. I'm especially proud of our proposal to maintain family connections in foster care, which was informed by discussions with the community. I'm also pleased that we're able to do more for children and their families living in deep poverty. That is a family of 4 with an income of no more than $905 a month. The governor's supplemental budget funds an annual cost of living adjustment for the Minnesota Family Investment Program. A COLA will put in motion an automatic increase that will continue to incrementally improve the well-being of children in deep poverty, so we don't have to wait another 35 years to get an increase.
Thank you. Commissioner Harpsted? There we go. Please continue.
There we go. And as I mentioned, we're putting together a whole plan for getting back to better, not back to normal. It's going to take something to come out of COVID, just as it took to pass 115 waivers to get people through COVID. And I'd like to turn it over now to Kalani Moti, our Inspector General.
Ms. Moti, welcome to the committee.
Thank you. Thank you, Madam Chair, committee members. My name is Kalani Moti, and I serve as the Inspector General here at DHS. And as you all know, that as part of the waivers that the Commissioner had approved, one of them is in regards to the background study requirement modification, which allowed providers to quickly respond to their changing workforce needs, including waiving the requirements for fingerprint-based background studies for most categories and instituting a Minnesota-only background study using an individual's name and date of birth for maltreatment and criminal history checks for most providers. That is, there's going to be some challenges in returning to the standard background studies procedure. To date, we have over 135,000 modified or emergency studies using name and date of birth. And it is anticipated that this number is going to continue to grow as long as there is a peacetime emergency in effect. Following the end of the state of emergency, all study subjects will be required to submit a new background study using fingerprints in order to ensure full compliance with state and federal background check requirements. The 60-day transition timeframe in the current statute is not going to be sufficient to allow a successful return to compliance. So what we are proposing to address the transition time and cost is extend the transition time to 365 days, add temporary FTEs to handle the increased volume of studies that we anticipate, and provide credit for previous emergency studies and cover resubmission costs for studies that are conducted under interagency agreements. So the investment in 22-23 would be $7.7 million, with adding in 9 FTEs, temporary FTEs, to be able to handle this. And this would also include some systems costs and changes. And with that, I believe the next presenter is Matt Anderson.
If I
Unless there
may,
are questions.
Ms. Moti, the background studies, that lag can be directly attributed to COVID. Why are we asking for general fund money to do these background studies? Or am I not reading this correctly?
And that one I might have to, Madam Chair, I might have to phone a friend on that one. I don't know if either Commissioner Harpsted or Matt Burdick.
Thank you. We can just leave the question, we can leave the question out there and then at the end. But thank you for accommodating.
You're welcome. I believe.
Good afternoon, Madam Chair.
Matt Anderson, welcome to committee.
Yes. Thank you, Madam Chair. Again, my name is Matt Anderson. I'm on staff at the Department of Human Services and wanted to go through a few of the suggestions in the governor's supplemental budget for helping us in these transition and a couple of the other changes related to our Medicaid and Minnesota Care programs. So first, to ensure a smooth transition for our enrollees from the end of the federal public health emergency and the requirements that are in place during that emergency, we are recommending a few actions in our healthcare programs to streamline processes as programs return to more permanent operations and minimize the burden on our enrollees, as well as our partners, the counties and tribal nations that help us process those enrollments. So the first suggested change or recommended change is temporary suspension of periodic data matching in our Medicaid and Minnesota Care programs. Periodic data matching uses databases, pings databases to find out if there's new information or updated information that may indicate that someone who is enrolled in a program is no longer eligible for it. This is something that we usually do on a rolling periodic monthly basis. It's been suspended during the public health emergency because we are keeping everyone enrolled as a condition of our state policy to help people maintain access to coverage, as well as being able to make sure that we're eligible for enhanced federal matching funds for our Medicaid program. When the federal public health emergency ends, we're going to have to go through and redetermine eligibility for everyone on our programs anyway. And so by temporarily suspending the periodic data matching, we're avoiding the confusion and the workload for our staff, but mostly the confusion for enrollees, as they would be getting multiple messages, some from the periodic data matching process, others from our re-enrollment or re-eligibility determination process. And so if we can suspend that for up to 6 months, may not require the full 6 months, but up to 6 months, that will allow us to get through the redeterminations, process everyone to make sure that people really are eligible, and then begin the periodic data matching again when we are able to renew operations as normal. Second is we are asking for state authority to waive unpaid premiums. Again, as I said, the federal law requires us to keep people enrolled even if they don't pay premiums during the federal public health emergency. This means that some people have missed or failed to pay their full premium during the public health emergency and have been accruing that as a outstanding debt. Federal law will prohibit us from recuperating unpaid premiums in the Medicaid program, and we are asking for the ability for those enrollees, as well as for our Minnesota Care enrollees, to not have a balance of unpaid premiums after the public health emergency ends for all of our enrollees. Then ensuring a sound rebasing methodology. This is in recognition of some of our payment methodologies that use a base year, particularly for inpatient hospital services. We base hospital payment rates on a particular base year of claims and data from what hospitals provided services to our members, how many services they provided, the acuity of those services, that sort of thing. What we know is going to happen is, because of the massive disruption in utilization from 2020, is that we're going to have a period or multiple years where we don't have sufficient claims, or where the claims really aren't reliable to adequately measure the value of services that hospitals provide in a given year. And so we are asking for flexibility in the methodology to be able to use more than one year as the base year, to be able to have more predictable and reliable payment methodology calculation process. Then finally, in terms of the returning from the COVID emergency measures, is we have additional requests for funding for electronic income verification. Federal law requires employers to be contacted to verify the work status and income of an applicant for either cash assistance or our healthcare programs. We have a contract with a vendor that enables counties to collect this information. That contract requires us to pay a fee for each time an employer is contacted. Because we have so many people who have been maintained in coverage and haven't gone through eligibility, we're going to have a much higher volume of contacts to employers that are going to need to be made after the public health emergency. And so this just basically recognizes that those contracts are going to be more expensive in the very near future than they would be in a normal year. Next slide. We also have proposals to conduct studies related to a public option. This proposal would give DHS the funding to contract with vendors to conduct a comprehensive study examining options to leverage federal funding and waiver authority to expand access to healthcare for more Minnesotans, and look at the adequacy of our current outpatient payment rates and identify a comprehensive approach to a revised rate setting for the Minnesota healthcare programs for both Medicaid and Minnesota Care. Minnesota, as you know, has a long history of healthcare innovation, but yet too many Minnesotans struggle to access healthcare coverage or services or be able to afford the coverage that they're able to get. The complexity of the various rules related to eligibility and financing within our healthcare system and the uncertainty at the federal level on policy directions have been barriers to creating a more strategic way to ensure that Minnesotans have access to affordable healthcare coverage. However, there are increasing signals from DC that the federal government may be supportive of state action to expand healthcare coverage via a public option, and Minnesota has the opportunity to take action to plan a meaningful path forward that leverages federal funding and improves our residents' access to both healthcare coverage and services. As a base of that, of any reform effort, is the notion of the payment rates that our healthcare programs pay to our providers. For our outpatient payments that are used for paying providers and other healthcare professionals are outdated. Various add-ons and supplemental payments and enhanced rates have been layered on over and over the years onto this outdated fee schedule. And this creates a rate system that lacks transparency, is overly complex, and is confusing for providers, and is really largely ineffective in addressing the disparities and promoting quality of care that our enrollees should be getting. So this would include a comprehensive study to examine the rates relative to the cost of delivering services, to avoid undermining the integrity and soundness of our provider reimbursements relative to one another when we expand healthcare access to coverage. Addressing rates in an integrated and comprehensive way will also help advance the integration of services that will help promote equity. So this proposal changes the medical assistance reimbursement for, next slide. The DME proposal, as originally proposed by the governor in his January budget proposal, includes changes to the medical assistance reimbursement formula for durable medical equipment, or DME. If DME is also covered by Medicare, but is not currently subject to upper payment limits, this proposal would have us pay for that at the Medicare rate. This would be an average savings of about 2.65% for our fee-for-service durable medical equipment claims. In the supplemental budget, the governor is removing pressure support ventilators from this reimbursement rate change. These ventilators are specialized, and providers need to be able to access those providers those ventilators to be able to care for patients, including pediatric patients. And so this proposal would remove those ventilators from the payment changes. The difference between the upper payment limit and the regular DME payment for those would be state funded. And then last is the pharmacy benefit. This proposal simplifies, recognizes that the copay differential that's in current law, $1 for generic drugs and $3 for brand name drugs. There are times in the preferred drug list where a brand drug is actually preferred to a generic drug, either because of it's more cost effective or it's safer or more effective. In those circumstances, when the brand drug is preferred, this proposal would allow for our enrollees to continue to just pay the $1 copay instead of the $3 copay, because they are using the preferred drug. They shouldn't be subject to the higher copay. The next slide, I believe, I'll turn it back over to the commissioner.
Commissioner Harpstead.
That is all. I did want to follow up, Chair Benson, on your question about federal funds versus the state general fund. And as you know, the timing of the governor's supplemental budget release and the early information about the availability of federal funds was awkward. And as we checked with MMB, they wanted to be sure that the governor could submit a clean, well thought out budget, and then we're going to go back and take a look at whether or not federal funds are an option on any of our proposals. So we'll be delighted to talk with you about that further.
Thank you, Commissioner Harpstead. I would appreciate a very rigorous, shall we say, approach to the use of federal funds in lieu of state general funds. In my opinion, anything that is COVID recovery, COVID caused, we should use federal dollars first to the extent they are available, which appears at this point to be in abundance. Senator Wickland, I'll go back to you while I wait for questions from members.
Thank you, Madam Chair. I guess I don't have any other remarks. I think it's helpful for us to see both of these, the Department of Health and the Department of Human Services revisions to the budget, so that we can see where the changes are. And hopefully, I think there are some very positive proposals in these bills, and I hope that you'll consider moving them forward in the omnibus bill. And I hope we can have continued discussions about topics like the public option and rate study bill. To me, seems like a very positive, or proposal seems like a very positive idea, given the number of changes that the federal government has made, extending programs into next plan year. I think it's good. It would be a good time for us to understand exactly how we can take advantage of the federal changes that have been made, plus study how we might make a path forward for our own rate structures. So that'd be one area that I just wanted to emphasize. But otherwise, if there's any other questions, let me know. Thanks.
Thank you. Senator Rosen, question.
Yes, my apologies, Madam Chair, and my apologies, Senator Wickland, too, for being tardy on this question. But it is to Mr. Anderson about one of the first slides he has, and I won't belabor this, but it said up to 6 months on temporary suspension of the periodic data matching. When does that start, and what is the criteria for that to trigger off? And then I have one other question, if you don't mind, Madam Chair.
Mr. Anderson.
Madam Chair, Senator Rosen, the periodic data matching is currently suspended under the federal public health emergency in order to help us maintain eligibility for the enhanced FMAP dollars. So when the public health emergency ends, we don't know exactly what date that will be, but when that ends, then this law, if this law is passed, this would kick in at that point from the end of the federal public health emergency through up to 6 months. Again, we would restore periodic data matching earlier than 6 months if we are able to move through our eligibility determination process for all of the enrollees in Minnesota Care and Medicaid to be able to catch up over the however many, by that time, how many months it'll be over a year, probably a year and a half for some enrollees remaining on the programs. So when we get caught up in those eligibility determination process, we would restore periodic data matching basically so that when those periodic data matching reports are run, they are actually capturing people who their eligibility is now questioned, or where there may be data where they are no longer eligible, not because they've been kept eligible during the public health emergency, but because something new has changed in their life.
Senator Rosen.
Thank you, Madam Chair. And just one more question, Mr. Anderson. How much debt has been accrued from the unpaid premiums on the Medicaid and Minnesota Care? Do you have a number there?
Mr. Anderson.
Do not have a number off the top of my head, but I will ask our staff, and if I get that number, I will try to flag the chair's attention.
Thank you. I appreciate that.
Mm-hmm.
Thank you. Further questions from members? Okay. Seeing none, Senator Wickland, Senate File 982, as amended, will be laid over for possible inclusion. Thank you, Senator Wickland. And now, members, we do have testifiers waiting for the Koran bill, so we are going to revert to Senate File 1371. Senator Curran, welcome to committee. Please proceed.
Thank you, Madam Chair. 1371 is a bill that goes after dental care for Medicaid patients and the procedures and process, and the goal is really streamlining the administration. This bill is designed to simplify the administrative processes for dentists who want to create and treat Medicaid patients. It addresses two of the biggest headaches and challenges they have: the prior authorization process for dental procedures and credentialing by payers for new dentists, which some of the plans now do through an electronic app. Each payer does these somewhat differently, and the goal is to standardize and to simplify and put the resources to providing care instead of the administrative pieces. DHS would be required to work with all the payers to make these processes uniform. They are currently helping to provide some technical assistance to the advocates and an estimate to whether there will be a cost for implementation. This legislation is not new. It was introduced by my colleague, Senator Klein, a couple years ago, and the bill has the support of the dental associations and the plans and the Safety Net Dental Coalition, who treat a majority of the people on the state public programs today. And with that, Madam Chair, I think what we'd like to do is, before we get to the speakers, we have our first one, the A4 amendment, and I'd like to move the A4 amendment to Senate File 1371.
Senator Curran moves the A4 amendment. Senator Curran, this is a delete everything amendment. Would you like to treat it as an author's amendment, and then we can begin discussion of specific provisions?
Yes, Madam Chair, I'd like to treat it as an author's amendment.
Senator Curran moves the A4 amendment. Please turn on your video and your microphone. All those in favor say aye.
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 Any opposed? Hearing no opposition, the A4 amendment is adopted. Senator Curran, to your bill as amended.
Thank you, Madam Chair. I did cover the contents of the bill, and what I'd like to do is have the speakers cover the finite details of the bill and why they're for it.
Okay, thank you. I have Dr. Sheila Riggs on our testifier list. Dr. Riggs, you have on your video. Please introduce yourself and begin your testimony.
Madam Chair, members of the committee, for the record, my name is Dr. Sheila Riggs, and I'm chair of the Department of Primary Dental Care at the University of Minnesota School of Dentistry. And I also chair the Dental Services Advisory Council, which advises the Department of Human Services. I'm testifying today on behalf of Minnesota Dental Homes Collaborative, a collection of critical access dental providers who have met weekly for over 15 months in an effort to identify opportunities where nonprofit dental clinics, private practice dentists, and educators in the field of dentistry could collaborate on public policy initiatives that sought to expand access to dental care and address disparities in our current delivery system. I want to start by thanking Senator Curran for authoring this important legislation. The Minnesota Dental Homes Collaborative strongly supports legislative reforms to increase efficiency in Minnesota's public health programs. Uniform provider credentialing and prior auth procedures amongst the public program payer community would decrease our administrative burden and allow the limited resources available to safety net clinic providers to be better directed to patient care. So we also strongly support the fee schedule transparency language included in the A2 amendment. The Minnesota Dental Homes Collaborative would also like to express its strong support for the dental home language included in the A2 amendment. As I said earlier, about 15 months ago, I convened a large group of the critical access dental providers after a few providers bought data from the Department of Human Services showing that fewer than 300 critical access dental providers in the state account for over 2/3 of the Medicaid enrolled dental workforce. And please know there's about 4,000 dentists. So there's 300 of us who are meeting the needs of 2/3 of the Medicaid enrolled enrollees. We all agree that elimination of the CAD program which you all have been talking about at the Capitol for years, without something designed, tested, and evaluated to replace it, would put the entire safety net provider community in financial peril. However, while the safety net provider community absolutely relies on the CAD program to keep its doors open, we also understand that not enough people are able to access care, and we do need to evolve in order to better serve Minnesota. We believe a dental home delivery model would meet the oral health needs of Minnesotans while also providing for provider reimbursement that's based on the care they provide and the outcomes they achieve. A patient-centered dental home is a model of care that's accessible as it allows for multiple entry points into care for the enrollee and uses the entire oral health workforce in innovative ways to ensure continuous and coordinated care that is patient and family-centered. Our new coalition, the Minnesota Dental Homes Collaborative, is committed to working with the Department of Health and the Department of Human Services and other stakeholders to develop the dental home pilot projects. This development process should be deliberative and data-driven, and we need to improve access to dental services and improve outcomes through evidence-based innovations, workforce changes, a more suitable and ethical benefit set to improve enrollee health while demonstrating value for taxpayer dollars. So thank you for the opportunity to testify today, and I'd be more than happy to answer any questions you have.
Thank you. Questions from members? I do have another testifier on the list. Mr. Yulin, you had indicated earlier that you were concerned about the A5, but if you'd like to testify to the A4, I'm happy to take your comments.
Great. Thank you, Madam Chair and members of the committee. My name is Joel Yulin. I'm the Associate Vice President for Public Affairs at UCare. UCare is a health plan that serves more than 550,000 members in Minnesota. I'm also here today on behalf of the Minnesota Council of Health Plans and here to testify in support of the Delete All Amendment for Senate File 1371. We share the goal of the committee to improve access to dental care for our members who are enrolled in state public programs. We've heard from the providers that one of the concerns that they have was with the administrative procedures. And we do not want administration to be a barrier for providers serving our public programs members. This proposal would streamline and unify several administrative procedures, including developing a uniform prior authorization process, the uniform credentialing process for providers, and provide clarity about the dental fee schedules. There's also the proposal that was mentioned earlier as well for the Commissioner of DHS to create a new dental home project. This is an innovative project that would establish and evaluate alternative models of delivery systems and payment methods to provide more options for our members. While none of these issues are by themselves the silver bullet that resolves the challenges facing dental services for people enrolled in state public programs, the Council of Health Plans does believe that this bill helps to address some of the core concerns that providers have raised. I would ask the committee to support the Delete All Amendment, and thank you for your time.
Thank you, Mr. Hewland. So members, the A5 amendment was distributed at my request. And Senator Cran and I haven't had a chance to discuss it, but I'd like to move the A5 amendment and amend it with the A6 amendment. The A6 amendment allows the commissioner to use federal benchmarks as a proxy for reading benchmark goals. So members, long before I got here, dental discussions were an issue, but they really intensified before I was chair, and have been trying to find solutions for the last 4 years. I am grateful for Senator Curran and the work that he has done on Senate File 1371 as amended. But I keep hearing that utilization goals aren't being met. And so setting benchmarks for utilization seems to be a reasonable step to take to make sure that Minnesotans get the care that we think we're paying for. I know recently there was an increase in dental payment rates for Medicaid patients. I find it frustrating, to say the least, that after years of conversation, the threat of a dental carve-out resulted in rates being raised. I can't say for certain that those two things were causative, and it might be just coincidence, but it is at the very least concerning that after years of trying to improve access through withholds and raising standards and making adjustments, that there is suddenly an interest in raising rates when there is actually a threat for a dental carve-out. And so, members, the A5 amendment sets a baseline in year 2019 and gives until January 2024 for some goals to be met. Now, the plans did remind me, and the department did remind me, these might not be actuarially achievable goals. And so I will not be asking for a vote on the A5 amendment, but I am not afraid of asking for continued aggressive change to make sure that the dental care that everybody tells me is so critical and that we continue to pay for actually starts to happen. Now, you'll notice at the bottom of the A5, I did include a carve-out, page 1, line 31, a managed care plan or county-based purchasing plan may be exempt from this single administrator option if they meet the goals. Because I really don't want to put more control in the hands of one entity, be it a government entity or a single administrator done through a competitive RFP process. Because there are some who are really trying to make this work, and they should be allowed to continue to do that good work. And you'll notice the administration of dental service is an outline of criteria that an administrator would have to meet, including choice of dental provider for the individual, participation requirements, payment rates established. The commissioner implements this section based on population, but it is only effective if the legislature determines, after submission of the calculations by the commissioner, that access improvement goals have not been met. So the legislature would have to continue working on this to enact this language as I've presented in the A5, as would be amended by the A6. Dental conversations have come to a head, finally, this legislative session. We need to find a way to meet the goals of getting access to those who most need it, who can benefit from it the most. And it wasn't until there was a threat of a dental carve-out that rates started being passed through to providers, which makes me think it could have been happening all along. And so with that, out of respect for actuaries and my colleague, Senator Curran, I will not be offering the A5, so I will withdraw the A5 amendment.
Madam Chair.
Senator Curran.
Thank you, Madam Chair, and I appreciate, I think everybody appreciates all the work that you've done and everybody to try and resolve this. I like the information from the conversation perspective. I think it does attempt to try and achieve the goals of accountability, yet preserve a healthy, robust private market everywhere we can. I have no goals and desires, and I'm sure you don't, as you stated, to have a single provider regardless of who runs it. So I look forward to continue to work with you on and everybody to make sure that we put some meaningful processes in place. And you know, I've also had many dentists reach out that don't currently serve Medicaid clients, and the simplification or the complexities, or even in a volunteer perspective, that they're prohibited from providing or giving away their services. And I'd love to continue to see how we can expand that network and availability across the state. So I appreciate it. Thank you.
Thank you, Senator Coran, questions from members as to Senate File 3171 as amended by the A4 amendment. Senator Wickland.
Thank you, Madam Chair. I don't have specific questions. I just wanted to say I do appreciate the bringing this forward and having this discussion, Senator Cran, because I think, you know, we all hear from our, well, constituents and advocates that we need to continue to work on access to dental care and this addition of a dental home pilot, I think would be a really positive step forward to look at some of the things that many of these providers have brought to me, is saying that they see people needing access to multiple services, and that can include, you know, different kinds of medical services. And so this approach of a dental home, I think, would be one that's really worth trying and studying. I think we do need to do more work, and I think your amendment gets at some of the other issues that we do need to address. And I hope that we can continue to have that discussion, because, you know, we also hear that rates, you know, that what providers are being paid is still not sufficient, and we need to understand, you know, what is it that needs to happen to make a difference, and to make sure that we have enough providers who are able to sustain their practices by serving the Medicaid population. So thank you.
Thank you, Senator Wickland. All right, Senator Coran, closing comments.
Thank you, Madam Chair. I think it was a great conversation about what we need to do and make some material changes. The time is now. We'll continue to work on it, and I hope we end the session with a viable outcome for everyone, and we make the changes, or ultimately put 1371 in one of our bills to actually move it forward.
Okay. Thank you. With that, members, Senate File 1371 as amended is laid over for possible inclusion in our omnibus budget bill. And members, we are moving to Senator Draheim, Senate File 2110.
Thank you, Chair. Senate File 2110 is building on what we did in 2018 with healthcare transparency. And back then, we passed the bill requiring clinics to disclose their price for the 25 most frequent services. And this was a path on what I thought was the first step in redoing healthcare a little bit, is to actually know what we're paying for healthcare. And this bill builds on that. So in 2018, the price disclosure showed how medical services prices already strongly correlate with Medicare allowed reimbursements. But the price disclosures cover just a few services. A great start, but we need more transparency, and we need it easier for consumers to understand and use. Recently, and I think it was December, the feds passed a no surprise bill and part of some larger packages. And this kind of goes and builds on what we were doing here. But I know we're way over in time, Chair, so I will go right to the testifier first and then come back, if that's okay.
Senator Draheim, we do have time for your bill, but we will go to Mr. Dave Racer.
Thank you, Madam Chair and Senator Draheim and members. It's good to see you all. Today, I'm here representing the Minnesota Association of Health Underwriters, who have taken a position in support of 2110. And we do salute you for the work you did in 2018. We thought it was a good way to plow the field and get it started, ready for more price transparency. You passed it 126-0 in the House and 65-2 in the Senate. I don't think the people believe you ever do that, and that was terrific. Consumers, however, still can't make price comparisons on most medical and hospital services. And it's important for consumers to be able to shop. About 80% of healthcare is shoppable. Consumers really cannot easily compare the price of care between providers. And today, a consumer actually signs a blank check and a promise to pay, that they'll pay whatever they have to pay to get the service that they're provided. This bill empowers consumers by giving them an understandable, simple, single price point. Not just the payers and providers now will know the price of care. The bill promotes full, transparent price competition among providers at consumer level, requires full disclosure of a single price we call the Medicare percent. The patient will only need one number from each provider as compared to a basket of incomprehensibly complex DRGs and CPT billing codes. The Medicare percent is the percent that a provider, let me repeat this a little slower. The Medicare percent is the percent that a provider accepts as full payment, regardless of network. The bill specifically respects the privacy of contract terms between payers and providers, and it does not set prices. All it requires is disclosure of one number, the Medicare percent, the percent of Medicare that a provider accepts as full payment. And we recognize this is a significant change in paradigm, and it will cause some discomfort, but change does that. The Medicare percent disclosure will especially be valuable to uninsured individuals and those with HSAs and high deductible health plans who really today can't shop based on price, as well as the increasing number of Minnesotans who want to shop for medical care. The bill also proactively eliminates surprise medical billings before they happen. The bill requires a provider to disclose in writing to patients two critical facts before administering care. First, it requires a provider to disclose whether a patient's insurance covers the proposed medical services, and secondly, whether coverage is in-network or out-of-network. There's also a provision in the bill to protect incapacitated individuals from surprise billing. You'll find that at line 4.28 and following. A current law allows a provider to require patients to sign an open-ended promise to pay contract, and this exposes patients to provider bills that could end in financial ruin and bankruptcy. So this is a patient-first bill, simplifying price transparency, allowing for shopping and comparison of prices between providers to create more competition.
Thank you. Ms. Janet Silversmith.
Good afternoon, Madam Chair and members of the committee. My name is Janet Silversmith. I'm the CEO of the Minnesota Medical Association. Appreciate the chance to offer a few comments on Senate File 2110. The MMA appreciates the spirit of this bill, but we actually believe that it presents a number of practical challenges for providers and frankly is likely to create more confusion rather than to add clarity for patients looking for comparative cost of care information. As you just heard, the bill would require providers to add Medicare percent, the percentage of the Medicare allowable payment rate the provider will accept as payment in full to patient bills. In practice, however, with the exception of care provided to uninsured patients, the amount a provider will accept as payment in full is already defined in a provider's contract with health plans. So it's unclear how the addition of, for example, 183% of Medicare added to a patient bill adds relevant or frankly actionable information to for patients. It's also important to note that there are many services that do not have Medicare allowed amounts, making this requirement even more confusing. For example, well baby and child exams are not covered by Medicare, hence they have a $0 Medicare allowable amount, which would make the Medicare percent 0% to be disclosed by a provider. The bill also requires providers to determine in advance of providing any services whether the planned services are covered by the patient's health plan. And as ideal as that would be, in reality, most services provided to a patient can't be known until a physician actually examines a patient and makes a determination of the services that are needed. Even many of the services that are required today to receive a prior authorization come back with a large caveat that indicate that the insurer's authorization is in fact not a guarantee of coverage until the claim has been submitted and adjudicated. Subdivision 4 is confusing as it appears to apply facility payments to professional services. Subdivision 5 of the bill would require providers to include a patient-signed Medicare percent disclosure form with all claims that they submit to health plans. As you know, Minnesota law requires the submission of electronic claims, and this requirement would be a significant departure from current state and national billing standards and would likely cause significant disruption in the claims processing. Finally, this bill would add state set payment rates for services provided to a patient who was either unconscious or unable to sign the Medicare percent disclosure form. This rate setting policy, in our view, is a fairly drastic solution to an unclear problem. In summary, the MMA appreciates the comparative information that this bill is attempting to create, but we believe the solutions proposed by this bill will not result in meaningful benefit to patients, which what they want to know is what they personally will be responsible for paying, and will also create a significant burden for providers. Thank you for your consideration. I'd be happy to answer any questions.
Thank you. Mr. Joe Schlinder.
Right. Thank you, Madam Chair and members of the committee. My name is Joe Schindler, and I'm the Vice President of Finance Policy and Analytics with the Minnesota Hospital Association. I am here today to address our hospital and health system's opposition to Senate File 2110. This bill is not about price transparency. It does create a penalty by setting medical prices at Medicare rates, which would destroy the current healthcare system in Minnesota unless there would be significant increase to the Medicare payment rates. The bill creates an immense administrative burden for providers to develop an ill-defined Medicare percentage. It then requires patients to sign a document showing they have reviewed this Medicare percentage, and the provider needs to send it to the health plan. For what purpose? Health plans and providers already have negotiated payment rates. The bill puts the onus on providers to notify patients about covered services and potential out-of-network services. This is the responsibility of the health plan working with their enrollees and should not be shifted to providers. While this bill excludes patients from Medicare, Medicaid, and Minnesota Care, it creates administrative hurdles when dealing with commercially insured patients. The proposal establishes a confusing price comparison with Medicare and a mandate to share the information with patients covered by private insurance. MHA estimates the current Medicare fee-for-service reimbursement to hospitals is 84% of costs on average. That means hospitals are losing 16 cents on the dollar for every Medicare patient they treat. For Medicaid, the rates are even lower at an estimated 74% of cost. There's little doubt there's cost shift that exists in healthcare, with the health plan payment rates needing to be above cost to help offset the losses from government payers. If the goal is to educate those with private insurance about the cost shift in healthcare, this information could be part of an annual enrollment information from the health plans or posted on MNsure. Just as a reminder, providers already have multiple state and federal mandates to share price data, including a state mandate in 2017 to post the Medicare, Medicaid, and commercial payment rates for the top 25 services. In closing, I'd like to share some perspectives on the current state of hospital and health system financials, which have declined in recent years and are very fragile. In 2019, the median operating margin for hospitals and health systems was 1.4%. That means half were above and half were below that amount. In fact, 31 health systems, or 41%, experienced negative operating margins in 2019. And I'm sure the picture will be worse when we look at 2020. I thank you for your time and consideration of my comments.
Thank you. And Ms. Twyla Braze.
Thank you, Madam Chair. My name is Twyla Braze. I'm formerly an emergency room nurse and now president and co-founder of Citizens Council for Health Freedom, a patient-centered organization that seeks to protect patient and doctor freedom. Unfortunately, due to the COVID-19 restrictions we're all living under, we've not been able to commit our numerous concerns or communicate our numerous concerns with Senator Draheim. The problem of price transparency, we believe, is primarily due to third-party payment. And we believe that despite the author's intent, the bill, if enacted, will have a number of serious impacts on both patients and doctors. So I'll list them up front. They include impossible requirements, increased costs, expanding bureaucracy that shifts yet more attention from patients to paperwork. In addition, the threat of a $1,000 fine, the threat of no payment for services rendered, price controls, limits on provider freedom, delays in care, and unfunded mandate, and likely rationing of care. Under cost, bureaucracy, unfunded mandate, and impossible requirements, we put the requirement that before any services can be provided by the provider staff must know the needed services, almost as though medical care was as simple as picking widgets off of a shelf. But as an ER nurse, I know this is not true. You never know what's going to happen. So they must also compare these services, known or not, to the details of each patient's health plan and must know whether the provider is in the patient's health plan's network. This will not only likely delay access to care, which could increase the cost of the patient's medical services, but it will increase staff and technology requirements and altogether increase the cost of every medical service. Other costs include the required Medicare percent disclosure form, the possibility of a $1,000 fine if some staff member forgets to provide the form or fails to turn it in, or legal costs if a patient says they didn't understand it, particularly if it's just one of many paper or electronic forms patients must sign. Then there's the lack of payment providers face if their staff makes an error on the questions of needed services, coverage of services, or network participation. Regarding delays in care, the requirement for knowing services in advance, determining coverage, and determining network participation will likely cause delays in care. Look no further than prior authorization for how that requirement alone delays patient access to care. We see the possibility of healthcare rationing coming out of the Know the Services in Advance section starting on 2.28, and the prohibitions on billing patients, the $1,000 penalty, and the unconstitutional requirement that every provider with any kind of relationship with a hospital, clinic, or healthcare facility must limit themselves to whatever the facility decides to charge patients or reimburse providers. This provision clearly limits practitioner freedom, which will limit patient freedom. Price controls always lead to reduced supplies of whatever item is being price controlled. In this case, we expect patients will face restrictions on access to care. The price transparency issue the author is attempting to solve highlights the real problem, that Americans no longer have medical indemnity insurance, real insurance, the kind that is network free. Thank you, Madam Chair.
Senator Draheim, I saw your hand go up, but wanted to let the testifier finish. Senator Draheim.
Thank you, Chair, and I was hoping you'd catch me after she was done. Thank you, testifiers. I guess my first question would go back to Mr. Schindler. And what part of the bill, I was looking it over here, but what part sets a price? So I don't.
Mr. Schindler?
Madam Chair and Senator Draheim, in, I think it was subdivision 5, if I'm not mistaken, if the copy of the disclosure is not provided, that they would be forced to accept the Medicare payment rate?
Senator Draheim?
But it doesn't set a price. The whole object of the bill, I know the first testifier said an unclear problem. Well, I think the problem is that we don't know what we're paying for our health care. And this is a journey to try to improve that process. And this is one way to tackle it. You already know Medicare price structure. You already have that. And I think your statement was a little misleading when you talked about developing a Medicare price structure. You already have a Medicare price structure. And this bill builds on what you already have. Do you agree with that,
Mr. Schindler?
Yeah, Schindler, Madam Chair, and Senator Draheim, we have Medicare fee schedules that we know and understand. What we don't know is what several of the testifiers mentioned, which is we don't know what services are going to be provided all the time ahead of time. And so the other piece here is that there's already a negotiated rate with the health plans So trying to fit a round peg into a square hole, trying to fit those prices in some cases, which are constructed differently than how the Medicare program is set up, would be a very labor-intensive administratively burdensome process.
Ms. Chair,
Senator Draheim.
I believe you already have to have the prices already in place. So I don't think there's any work to be doing there, but I think we're missing one piece here. We are not communicating whatever negotiated it is with the healthcare insurance company. The consumer doesn't know what the price is. And that's what we're trying to get at here, is so the consumer can be notified and be transparent on, I think it's 80% of the procedures would qualify under this bill. So that's what we're getting at here.
Thank you, Senator Draheim. And you know, I have a number of friends who have participated in some of the cost sharing plans. And it is like pulling teeth to get clarity as to what they're supposed to pay. It is just about impossible. And we're not asking anybody to disclose proprietary information negotiated with the health plans. We're asking you to take a fee schedule that already exists and say, this is what it would, if you paid out of pocket, this is what it would cost. And so, there need to be some fixes, Senator Draheim. We could exempt well baby checks and anything Medicare doesn't cover. But how are people supposed to know what they pay? And, if you're going in for a procedure, you schedule your appointment. It might be urgent, but not emergent. And then you find out your anesthesiologist isn't in your network. How's a patient supposed to know that? Who better than the person doing the scheduling to look at your insurance coverage and say, oh, they're out of network? I mean, surprise billing is an actual problem. And I haven't seen anybody from providers or health plans coming forward with you know what, you're right. The person who is in need of medical treatment should be a better consumer, but they're also the least, well, I don't want to say unsophisticated, but the insurance billing department at a hospital or clinic certainly is much more sophisticated than even myself walking in and saying, can you tell me if everybody's in my network? At least I know to ask the question. So, Senator Abler.
Well, thank you, Madam Chair. And I think this is a really good discussion. And I have to tell you, the doctors don't know what things cost. I know in my clinic, I have no idea what I'm going to get reimbursed. Mostly, we're on the low end, so I can just tell it's not going to be much. But it's we don't know. And if we ever need to get our arms around the costs and even quality, people need to know. There's no other place that you don't know what it costs. Even the car dealer has to give you an idea of what it might run to fix your engine and be within a certain percent of it. Otherwise, and then you have, hospitals that have people that their job is to kind of make sure you didn't forget to charge the $40 for the aspirin or whatever it is now, so they can make sure all the bills are high enough. So, Senator Draheim, good for you, and to the people with concerns, help us find a way. At some point, this is costing some real money, and we've just recently enjoyed a great influx of money from the feds that they're going to help reduce what people pay to almost nothing for their health insurance. So it's all going to be free. And it's not free. It's one of the biggest costs there is. And some of the biggest things that you spend money on are really not even a good idea. And if you knew it would cost that much, you go like, really, that's a lot. But it's whoever invented the hospital copay of $50 really just served the healthcare system. Because what's it cost to go to the hospital? Oh, $50. Oh, well, let me, what else you got? I'd like, while I'm here, why don't you do everything? And we've had this discussion since I've been around. And if you really want to get after quality and cost and preserve access, you have to know this kind of question. So thanks, Senator Draheim. And I appreciate the concerns from the people that have the concerns. But The answer isn't just block this bill and move on with status quo. The answer is find a way so we all can get the care you really need. So when you really need it, you're not going to die because somebody is not available to get what you need. So I'll stop, Madam Chair. Thank you very much.
Thank you. Senator Rosen.
Thank you, Madam Chair. The last two bills have been pretty heavy lifts, I have to admit. Senator Graham, I do have a question on your bill, even though it's got great potential, but I am a little concerned about the $1,000 fine to the provider if they don't give them a form or a disclosure form. Was that modeled after another state, or where did that come from, if you could?
Senator Draheim.
No, I think I'll go to Mr. Racer on that one.
Mr. Racer.
Again, thank you, Madam Chair, Senator Rosen, and members. It's an area of the bill that we had a tremendous amount of discussion about. How do you put enough into the bill to make sure that providers comply? And the whole idea was a small fine, which could be significant for a small clinic. I understand that. And maybe the fine isn't $1,000, maybe it's $100. But the idea was there had to be some teeth in the bill.
Senator Rosen.
Thank you, Madam Chair. And Senator Graham, I hope you take a look at that. I think that is extremely heavy-handed. And I am thinking of my smaller clinic that I go to in Fairmont, and that would be a tremendous burden for them.
Chair,
Senator Draheim.
I'm willing to work with anybody, as always, on any of my bills. But that definitely could be ironed out a little bit and tone it down quite a bit. So I appreciate the comment, Senator Rosen.
Thank you. Senator Abler, your hand is still up, but your video is not on. I'm going to presume you don't have a question. Thank you. So Senator Draheim, I hear two things. People can't tell what they're supposed to pay when they engage with the medical system. And for people who have an HSA, people who are in a shared healthcare spending program, people who are uninsured, they end up wandering around blindly through this maze of healthcare costs, and nobody is speaking for them. So I want to thank you for speaking for them. And secondly, for people who have coverage, have healthcare coverage, surprise billing is a real problem. And I haven't heard any real solutions to the surprise billing problem. And so Senator Draheim, you expecting the people who have the most likelihood of being able to get that information, seek that information, is at least a good option to put out there. And so I want to thank you for continuing to be an advocate for people who are left out of a lot of our healthcare conversations. We talk a lot about public programs. We talk a lot about expanding services and care, but there are some people who have really direct economic impact from their healthcare, from their impact with the healthcare system. And Senate File 2110 speaks right to what their experience is. So Senator Draheim, any closing comments?
No, I appreciate the discussion, and this isn't going away, members. We need to continue to work on that. So I appreciate your time here.
Thank you. And with that, Senate File 2110 is laid over. And Senator Wiklund, your third bill of the day, 2114.
Thank you. Thank you, Madam Chair. I do have an author's amendment for this bill that I'd like to it's a technical amendment that I'd like to move forward, the A1.
Senator Wiklund moves the A1 amendment. All those in favor, turn on your video, turn on your audio, say aye.
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 Any opposed? Thank you. Senator Wiklund to Senate File 2114 as amended.
Thank you, Madam Chair. And this is the Department of Human Services, the Healthcare Administration's policy bill. And I do have, there is Ann Bobst here from the department, and she's going to actually walk through the different sections of the bill to explain what each section does. So I will turn it over to her. Thank you.
Thank you. Ms. Bobst, please proceed.
Thank you, Madam Chair. For the record, my name is Ann Bobst, and I am with the Department of Human Services. And I'd first like to thank Senator Wickland for carrying this bill. As she mentioned, this is the department's healthcare policy bill, so I'll provide just a brief walkthrough of the sections in the bill for members, and then I do also have policy staff on hand who can help with any technical questions. So sections 1 through 5 of the bill clarify where in statute the coverage mandates for public health care programs versus coverage mandates for private plans live. We often see proposed coverage or benefit mandates in these sections that, if passed, would apply to the managed care plans that offer medical assistance and Minnesota Care coverage. And this can create different covered benefits within the medical assistance and Minnesota Care programs for enrollees in managed care versus fee-for-service. Then additionally, in order to receive federal funding for MA services, any new services need to be included in our state plan, which is subject to approval by CMS. So any mandates expected to be implemented by the managed care plans that are not in the state plan would not be eligible for federal funding. And I do want to note that this proposal does not make any changes to current medical assistance or Minnesota Care coverage. Sections 6 through 8 of the bill are primarily technical updates to improve the functions of the Health Services Advisory Council. The Health Services Advisory Council, or HSAC, advises DHS in designing healthcare benefit and coverage policies for our publicly funded healthcare programs. These changes include updating the name of the council in statute, where it currently is referred to as the Health Services Policy Committee. It also clarifies the charge of the council and removes outdated language. It also increases the number of consumer representatives from 1 to 2, expands who can serve as a representative of the mental health provider community, and allows any voting member of the council to serve as chair. Section 9 of the bill repeals the sunset of the Drug Formulary Committee, which is currently scheduled for June 30th, 2022. And the Drug Formulary Committee is a committee of licensed and actively practicing healthcare providers who volunteer to evaluate the safe and effective use of prescription drugs in our public healthcare programs. Then the amendment provides some clarifying language to conform with similar language for other advisory committees. Section 10 updates statutes for the Child and Teen Checkup Program, which is Minnesota's version of the federally required early and periodic screening, diagnosis, and treatment program, in order to reflect the current policies and practices needed to operate the program. Sections 11 through 13 pertain to the Opioid Prescribing Improvement Program and the Opioid Prescribing Work Group. This will change the 2 existing consumer seats on the opioid prescribing work group from non-voting to voting status. It also allows DHS to share information about prescribers who are in line with standards. Currently, DHS is only allowed to give notice when a prescriber's practice merits quality improvements. Additionally, the amendment clarifies that a member of MDH sits on the opioid prescribing work group as a non-voting member, and this was language requested to be added by MDH. Section 14 repeals a requirement for DHS to enroll qualified professionals who work for PCA agencies as individual providers to correct a drafting error from final negotiations in 2019. Section 15 is a revisor instruction to update the name of HSAC across statute. And then finally, Section 16 repeals outdated rules related to the Child and Teen Checkup Program. And so, Madam Chair, that completes the walkthrough of the bill. And as I mentioned, I do have policy staff on hand who can help with questions.
Questions from members? I do have a question why we are changing non-voting to voting members. Senator Wickland.
Thank you, Madam Chair. For the opioid prescribing work group, changing the seats from non-voting to voting status, that's something that's been requested of the stakeholders that we work with in that program. And so this is something that we wanted to do in order to, take their feedback for the program.
Thank you. Senator Eaton, question.
Thank you, Madam Chair. I'm on the ORAC committee, and I we added the people that we have on there that, and have found them to be valuable and would like to give them a voice, a vote. But we couldn't do that because specifically in statute, we had listed who could vote.
Thank you. Looking for other members. Hands, okay. Seeing none. Senator Wiklund, closing comments.
Thank you, Madam Chair. I don't have any additional comments. I think that these policy bills are good to move forward, the changes that are recommended by the department, but I know you are planning to go through and look at all of these provisions and decide, if you have more questions, and certainly can be willing to help out if you need more help with it. Thanks.
Much appreciated. Seeing no further questions from members, Senate File 2114 as amended is laid over for possible inclusion in our omnibus bill. With that, members, we move to the last items on our agenda. Checking to see Senator Draheim, looks like he is available to chair.
Chair Benson, are we doing 2277 first, or?
Mr. Chair, let's start with 2277.
Okay. Two-year bill.
Thank you, Mr. Chair and members. We heard earlier that there's been a delay in the development of some of the price transparency work. This amends that section of law that allows the work of the price transparency committee, I'm sorry, I'm forgetting their name, to look at any other public information. For example, Oregon has more disclosures in their price transparency, and they glean more information instead of our department going and looking for additional information. They can just use what is gleaned and publicly available from the Oregon price transparency reports. And then the University of Minnesota has analytical tools, and we want to make this available as part of price transparency as well, so that to the extent it's informative, it can be included in the development of our price transparency disclosures. That is the extent of the language. Again, access to public data, access to work being done at the University of Minnesota can be included in price transparency work.
Thank you, Senator. Members, any questions on Senate File 2277? Senator Rosen.
Thank you, Mr. Chair. And I'm trying to turn, there we go. And Senator Benson, this is great, but I was just wondering if the University of Minnesota has signed off on their cooperation and their analytical tools that they'll be using.
Thank you, Senator Rosen. As part of developing the fiscal note, we will probably need to come up with some money to buy that, but they had indicated that we would have to buy some of this information. So that will be part of developing a fiscal note. Thank you.
Any other comments or questions, members? Senator Benson, any final comments?
Thank you, Mr. Chair. You and Senator Rosen have been working on finding the right line for disclosures and helping the public understand costs. I think this adds to the conversation, and again, publicly available already work product from a trusted source. And with that, Mr. Chair, I would move that Senate File 227 be laid over for possible inclusion.
2277, I believe. But
Yes, thank you, 2277.
thank you. Next up, members, we have Senate File 2193. Senator Benson, to your bill.
Thank you, Mr. Chair. Senate File 2193 relates directly to a recently emerging issue. There is a lot of information that is being collected on the vaccine connector And the legislature has not had a lot of influence, input, or transparency. And so what Senate File 2193 does still allows the connector to exist, to do its core function, but the data that they collect must be essential to the process of communicating vaccine availability. So name, address, phone number, or email address so that they can be contacted. Their date of birth, which goes directly to age, their occupation, because as we look at their status as an essential worker or in particular risk categories, occupation does matter. Health information as necessary to determine vaccine priority. So if you have one of the underlying conditions, sickle cell or Down syndrome, that would be important for determining where you were in priority. The need for a language interpreter so that if you need to be sent to a place that has interpreters or an interpreter given notice, that would be available to you. The data classification would be private. It could only be shared to the extent necessary for giving notice of vaccines. The commissioner and government entity may only use the data to alert individuals when they are eligible, connect individuals to scheduling, notify individuals of vaccine opportunities in their area, and prepare summary data. They are prohibited for sharing vaccine connector data with any other government or entity unless the data subject, the person submitting the data, has been informed about the government entity or the person who will receive the vaccine connector information. The data has consented to their information being shared. They have to have written procedures to ensure that only individuals who are authorized may enter, update, or access vaccine connector data. There has to be an audit trail. If data is going to be private, we have to know who's looking at it. Data destruction, let's see, within 1 year of the date it was initially collected, or June 1st, 2020, whichever is earlier, and then an individual can write to request earlier destruction. There is an audit required to make sure that this is being complied with, and remedies for violation are in existing law, Mr. Chair, and that reference, of course, lets us know that this needs to be referred to civil law. Some things, members, there's been a lot of talk about the information that is collected, and it is not clear to many people, and I recently checked the site, that just leaving something blank doesn't distort your position in the vaccine connector. I am not saying that there is an algorithm that does that. What I am saying is if it makes people question or concerned or creates a barrier, then it is not serving its most robust and key purpose. And Mr. Chair and members, are people told that their information could be shared with Homeland Health or Primary Bio? And do we know what happens to the information after it's shared with vendors? Do people check a box and say, it's okay for my information to be shared with Primary Bio? And so let's just get some clarity around what's going on. We don't want to stop people from signing up, and we don't want to get in the way of keeping people connected with the vaccine rollout. But let's make sure that Minnesotans' data is protected as we're doing this important work. And I know, Mr. Chair, the department has some comments. I am happy to adjust this to facilitate technical completion of their work. I did submit a letter to the commissioner and received a response, but this language fulfills things that weren't committed to in the letter. So, Mr. Chair, that is Senate File 2193.
Senator Benson, do we want someone from MDH to comment on that, or?
Mr. Chair, I am happy to take input, comments from the department, as always.
Is there someone from MDH that would like to comment on Senate File 2193?
Mr. Chair, members of the committee, I'm Joanna Dornfeld, I'm an Assistant Commissioner at the Department of Health.
Go ahead.
Thank you, Mr. Chair, Madam Chair, for bringing this bill forward and members of the committee. The Department of Health shares the priority that all to protect Minnesotans' data. And, as we've communicated, we are following all applicable laws as related to data as it works with the connector. And we do believe that the connector is an important tool to connect Minnesotans to the COVID-19 vaccine. So we really welcome the conversation about how to best use this tool. And if there's some improvements that can and should be made, look forward to working with the author to have further conversations about it.
Ms. Dornfield, if I could ask a question about the information shared with the vendors. So do you have an agreement with them that they can't share the information or what they can use and can't use? And can you share that with us?
That is correct. We do have a contracting agreement with the vendors that has data sharing requirements or limitations, I should say, not requirements, but limitations in it, but can certainly follow up with you with additional information.
So they're in the contract, it does have limitations on what they can use the data for and what they can collect. Is that correct?
I can't speak to the specifics of the contract, but we can certainly follow up with you and provide additional information. I don't want to misspeak, so I would just really want to follow up with you to be able to provide accurate information about specifically what's included in the contracts.
Okay, thank you. Senator Benson, did you have any comments or questions to that?
Mr. Chair, thank you. And I have worked with Ms. Dornfeld on several issues. I have tried to get the principles of this bill moved through conversation and a letter. This bill was being drafted as the letter was being responded to, but I didn't want to move it until I had gotten a response from the commissioner. And so there are some things that have changed since this language was drafted, and I'm happy to remove those provisions that have already been dealt with. But I do need to have some certainty that Minnesotans' information that is collected here is the minimum essential for doing the work that needs to be done, and that if it is shared with a vendor, that vendor can't use it for marketing purposes, that they're going to destroy it in a timely manner. So these conversations, were we designing a vaccine connector through the legislative process? These questions would have been cleared as it was being developed, but we didn't have that opportunity. And so we're going to have an iterative conversation about what changes need to happen to the vaccine connector. And I have confidence the department will continue to do sincere work. But this is my way of keeping the conversation moved to the next level.
Thank you. Senator Rosen.
Thank you, Mr. Chair, and thank you, Senator Benson, for bringing this forward. And Ms. Dornfeld, I really appreciate you coming in on this. I know you came in at the 9th hour, and so, yeah, we were probably playing catch up a little bit on fixing something that's already been rolled out. And I'm not going to, I have the connector pulled up right now. I'm not going to go through that. We have done, exposed a lot of the discrepancies and issues with this connector. I did go on the connector. I did a file because I'd like to get the vaccine, and I am having I'm having a heck of a time figuring this out, and now I regret going on the connector because I'm not sure if my data is going to be private. It's nobody's business. My children and their friends, my children are not vaccinated, but all their friends are, and they're in their 30s. And you tell me how they got vaccinated. And I'm kudos for them, but somehow this connector is not connecting the people that need to be vaccinated like they should be. So there's a little bit of frustration. And if it wasn't for my children that are looking on the website every single day to figure out how to get a shot, I would be, and I feel like I'm halfway intelligent, but I cannot seem to get this thing to work. So a lot of concerns there about my personal information being private, that it's not being shared. My regret for going on, and basically kind of a runaround of the whole program by people that, that's great. They're vaccinated, but there is a waiting list too. So, thank you.
Thank you, Senator Rosen. Senator Wickland.
Mr. Chair. I guess I would just like to say I don't think I could ever support this bill until I know specifically what are the things that are not being satisfied by the department today. I have a strong belief that they are using very strong privacy and security background that they use in a lot of the work they do or have done to this point to develop a system that is following the privacy requirements of our state. And so I would really like to understand, what are the things that are not being followed that you have in your bill. And then I guess Senator Rosen, I guess I'm not clear on why, how that could be a judgment on the vaccine connector. If there are people who are getting vaccinated who don't fall into the eligibility categories, I guess I don't understand how that would be connected to the vaccine connector tool itself. If that means that somebody's putting down information deliberately that's not correct, if that is what is happening, and that's why they're being advised of vaccination appointments being available. I guess that just isn't clear to me that the vaccine connector is what is the part in that isn't working properly or that you're having trouble with. And then I have concerns about this, the desire to put down in the bill, exactly what data should be collected. I think the Department of Health is working with a number of their staff and advisory council members and others to understand what information is needed to make sure that our vaccine distribution is done in a fair and an equitable manner. We know that communities of color have been disparately impacted by the virus, and it is important to understand the demographics of those signing up in order to make best efforts to get vaccine distribution sites available to all populations in an equitable way. And we can't just say that, well, we need a minimal set of information and that's enough to do it equitably. I believe it is important, and I believe the people who sign up who are members of groups that maybe have been disparately impacted will appreciate that the time is taken to collect information that is comprehensive, and so that we can make the best decisions about vaccine distribution. So I support the questions that have been included, and I think they are valuable. And I hope that we have a strong focus on racial equity as we go forward with designing our vaccine distribution system.
Senator Benson, any comment to that?
Thank you, Mr. Chair. I looked at the phases and tiering that were announced by the department as criteria for vaccine rollout. This has nothing to do with their placing vaccine clinics easily accessible, communities of color, community health centers. I am fully supportive of that and of them making sure that there is specific outreach. But when I look at phases and tiers, this is the information that's necessary. They were asking about insurance status. Why does insurance status matter when we're talking about a vaccine rollout? So I am as much as I like analytics, I am a data minimalist when it comes to the government collecting information. And so when the department publicly stated, these are the phases and tiers, and this is how we're making decisions, I decided that that was the most relevant information. That was critical. And I completely support them putting the department working with communities, making sure the vaccine is readily accessible. But if they're going to tell us these are the phases and tiers we're working on, then that's what the vaccine connector should sort by and therefore it should be what is collected.
Members, any other questions or comments? Mayor Wickland, or did you have another comment or question?
Yeah, thank you, Mr. Chair. I just have a comment. I guess I think that that's true, that the tiers and the phase may not differentiate down to that level, but we have to look at other data as well. And we know that we have data showing that even at this point, more white Minnesotans have received the vaccine than their percentage of the population, and fewer of some minority populations have received the vaccine and than their percentage of the population. And we need to be taking active measures to understand why that is and to do things about it. And I think having the information from the Vaccine Connector will allow people to be able to look at whether we have distribution sites that are meeting the needs of all of our all Minnesotans. So thank you.
Thank you. Senator Benson, any
Mr. Chair,
follow-up?
I would reiterate, there's no insurance criteria in the tiering or in placement of clinics. And yet it was a question that was asked. And I believe the department has done a very good job of reaching out to communities of color. They have made it a priority. And the reason there is a disproportionate number of white Minnesotans who've been vaccinated is because our older population is more white than the general population. And MDH said we are going to make 65 plus our mission for the first part of vaccine rollout. And so we're going to see rebalancing of vaccines because of the work that's being done at MDH to make sure that we are reaching out to those communities.
Thank you, Senator Benson. Any final comments, questions, members? Otherwise, we're gonna vote on this. We're gonna move Senate File 2193 to pass and be sent to civil law and data. So please turn on your cameras and your microphones. So all those in favor of moving Senate File 2193 to pass and be re-referred to the Committee on Civil Law and Data Practice, say aye.
Aye.
Opposed, say nay.
Nay.
Motion passes. Senator Benson, to your next bill, Senate File 1589.
Thank you, Mr. Chair.
And do you want to move this one? I think it's going to the same place too.
Mr. Chair, this will be moved to civil law. I do have an amendment, Mr. Chair. The A1 corrects a drafting error, just as sometimes vaccination comes up as vacation. So sometimes contact comes up as contract. And so, Mr. Chair, we're correcting a drafting error with the A1. I'd like to move that as an author's amendment.
So members, we have a A1 amendment, author's amendment to Senate File 1589. Please turn on your cameras and microphones. All in favor of moving the A1, say aye.
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 Opposed, nay. Amendment passes to your amended bill.
Thank you, Mr. Chair and members. And when digital contact tracing emerged, I realized there was some risk, a new risk compared to what had been traditional contact tracing, person-to-person contact. And so I began drafting this amendment that limits the department's authority to compel contact tracing, or for a state government to compel someone to provide their location information through digital contact tracing. This doesn't mean that if you are a PCA and have to prove that you're working on site, that your employer can't do that, but they can't use your digital information and share it. An individual can always consent to do this. An individual can always consent to have their data shared. The point here is that an entity, a government entity, cannot compel you to share that information. And then the second is you can't be required to disclose your immunization status or testing status to enter to participate with a state agency, local unit of government, unless you volunteer to do so. And you shouldn't have to display a health status on your person or as a requirement to prove that you don't have a communicable disease. So I know that Mr. Huff has some considerable concerns, and I would be happy to hear those now. But members, we can't forego rights in the middle of a pandemic. It's time for us to have that conversation that says it's important to be tested, it's important to be vaccinated, but it shouldn't be criteria for your participation in government or employment.
Anything else? Senator Benson?
No, Mr. Chair, I am happy to begin debate and answer questions.
Okay. Do we want to go to do you have testifiers on this?
I believe Mr. Huff, Ms. Braze did give notice that she wanted to testify.
Okay. Ms. Braze, are you available?
I am.
Okay, please state your name for the record.
Yes. Thank you, Mr. Chair and members of the committee. My name is Twyla Braze. I'm a registered nurse and president and co-founder of the Citizens Council for Health Freedom, a patient-centered, privacy-focused organization that seeks to protect patient and doctor freedom. So first of all, I just want to thank Senator Benson for this bill. And I have a few comments on Senate File 1859 and a few questions, several of which have come up since I first communicated with the author after my initial read of the bill. So first on line 219, we support the provision not forcing participation with contact tracing. We'd also support extending this protection to those whose names have been reported by the contagious to MDH. We'd request that the language require the health department and others to clearly communicate to all of these individuals that they are under no obligation to participate. In other words, someone who is contagious might say yes, but the people that are contacted afterwards should be given the right to say no. So this should include a Tennyson warning and a statement that should be written and in verbal form so it can't be missed. Second, on line 230, contact tracing will end, but disease investigation, we believe, could go on for years. This limit does not actually appear to have a limit, an actual limit. So we'd like a concrete end date so data is actually destroyed. Third, on line 233, we appreciate the requirement of voluntary consent for digital contact tracing, but we would like it to require that consent to be written and a Tennyson warning be given with the request for consent. Fourth, on line 3.29, what does it mean when it says except as otherwise provided by law? And I know I asked about the author about this, but I really am wondering what laws this pertains to and how big of a loophole this could create. Fifth, on line 4.10, we support the broad-based prohibition on government and private entities demanding disclosure of health status. Likewise, we support the ban on employers requiring contact tracing. However, we would also encourage the author and the committee to prohibit vaccination mandates by employers. Now, as a reminder, there have been thousands of injuries and more than 22,000 US deaths reported to VAERS, according to the CDC. The vaccine is a clinical trial until 2023, so we're all in a global research experiment. No COVID-19 vaccine has actually been approved by the FDA. The vaccine is not actually a vaccine. In other words, it doesn't stop the vaccinated from getting COVID-19. No one knows the long-term effects, and it's still considered an investigational drug. Every drug, I know as a nurse, has a long list of potential side effects. Some of them can be deadly. Citizens have a human right to refuse vaccinations and to not participate in research. Yet too many employees are facing a get the jab or lose the job decision. Lawsuits have already been filed. I would remind members of section 12.39 in our law, the 2002 provision of our Emergency Health Powers Act, which says, quote, individuals have a fundamental right to refuse medical treatment, testing, physical or mental examination, vaccination, participation in experimental procedures and protocols, collection of specimens and preventive treatment programs, end quote. Finally, on line 6.4, we appreciate that the author has included penalties, giving the bill real teeth should it become law. Thank you very much.
Thank you.
Thank you. Senator Benson, did you
Mr.
have any
Chair,
comments?
I feel like I need to be really clear. The FDA has these vaccines rolled out under emergency use authorization. And so I don't want there to be a public perception associated with my bill that there hasn't been an approval process. There's an emergency use authorization, and I think it's important that each of us, as educated, informed healthcare consumers, make a choice based on our health and based on our knowledge that the FDA has said this is suitable for emergency use. I also think that reporting adverse events is important as we gain more information. And so I want to be really careful. I am not telling people to not get vaccinated. I really think that is a discussion you should have with your healthcare provider based on your own judgment, with the best information you have available, based on the way that you might be exposed, based on the risks you might have to the vaccine, based on your own closely held personal beliefs, and not for public discussion. I take Ms. Bray's advice on disclosures and data very, very seriously, and I respect the need for that input. And thank you, Ms. Brays, for reminding us of 12.39. Minnesota, you spoke of lawsuits being filed. Minnesota does have protection for individuals so that you don't have to be compelled to have a medical procedure. This has to do with feeling compelled or having someone apply pressure to contact tracing. You can't be barred from interacting with your government based on your contact tracing or vaccination status. I think that's important for us to understand so that more people will be more comfortable and less threatened. We don't want force to compel a vaccine choice. We want engaged, informed consent to be the reason for that choice. So, Mr. Chair, I'm happy for other questions and comments.
Okay, thank you, Senator Benson. Senator Eaton, did you have a question?
Thank you, Mr. Chair. Well, I don't know if I have a question as much as, well, I guess I do. Senator Benson, at what point does the common good of the public come before the individual rights?
Senator Benson?
Well, Mr. Chair, I think this provides a really balanced approach so that people aren't compelled to be vaccinated. They aren't compelled to be digitally tracked as a condition of engaging with their government or their employer.
Senator Eaton, follow-up?
Thank you. Well, contact tracing has been in place for decades, and it's public health 101. It's science. It's how we make sure that a disease doesn't spread to the more vulnerable people. And to restrict it is it's anti-science. It's anti-public health. If I had to have a manto to work as a nurse because tuberculosis was a epidemic at one time, and because of mantos and that screening, it is not an issue like it used to be, and the same with a lot of the vaccines. I think that I think this is just being proposed as it feels very political.
Senator Benson.
Mr. Chair, we don't compel nurses to get the flu vaccine. And I do not think that you should have to wear or display a symbol or card that shows your disease status. We don't do it for measles. We don't do it for TB. And there has been a lot of conversation about saying, well, maybe people shouldn't go here, shouldn't go there, unless they prove they've been vaccinated. So I am willing to have a very robust discussion about what we're going to require to be disclosed. But members, we do not require disclosure of your measles vaccination status or your flu vaccination status. We don't compel people to disclose medical procedures. And if nobody was talking about this, I wouldn't have spent time drafting language that says you can't be required to display a negative or positive test result for a communicable disease. So it is for this committee to decide, and if Senator Eaton, if there are things you want to strike in this language, and if the Department of Health thinks it makes things unworkable, but we've moved from person-to-person contact tracing to digital contact tracing where proximity via Bluetooth can tell if somebody has been within 6 feet of one another. That should be voluntary. It shouldn't be a condition of interacting with your government or your employer. It is important. Contact tracing is important. But as a citizen, being able to decide who shares your proximity, especially in the digital age, is really important too. And everything has to be balanced.
Okay, members, any other, Senator Wickland?
Thank you, Mr. Chair. I guess I have a question about, I mean, you talked about not being forced to disclose immunization status, and yet I think we do have places where we require that. I mean, people when they go to college or when they go to school are required to do that. I don't see that the issues that you are raising are a problem today. I think the contact application that was deployed in Minnesota is purely voluntary. People are not being forced to use it. If they choose to, they can. If they don't want to, they don't have to. And to me, this seems like this bill will just put barriers in place that will affect, in a negative way, our ability to do public health work that needs to go on. And it just doesn't seem to me that the issues you raise, while true that people shouldn't be compelled to wear something to showing that, I'm not hearing that anybody has felt that that's been, they've been asked to do something like that. And I've not heard of employers making requirements that are beyond things that they can do today. So I have really strong concerns about the Department of Health being able to do the work necessary to track diseases and can do contact tracing in an effective manner if this bill was put into law. And I think it needs a lot more evaluation against what's our current laws state as far as privacy before we put into place a very significant bill like this. So I will be opposed to it.
Thank you, Senator Wickland. Senator Benson.
Thank you, Senator Wickland. The mandatory immunization statements, should governments be able to compel that without, except as otherwise provided by law? So child care centers, we do have immunization forms, and there is a process there, and colleges for admission. But do you think it should be a condition of going into the DMV that you disclose if you've been vaccinated? Should it be a condition of engaging with your government? So I don't want to go down rabbit trails people have talked about. You can't get on airplanes unless you disclose. This doesn't touch that. But that's an important part of the conversation as well. When it comes to contact tracing, if you volunteer to share your information, that is entirely up to you. If your employer says, we're going to do this for you, it better be with your voluntary informed consent, and it shouldn't be a condition of employment. So I am happy to walk the line between the rights of individuals and the need for public health. But there have been, the more we try to get people vaccinated, some are going to want to do it by encouragement and talking about the importance, and others will want to move to compelling behavior. I am in the encourage camp, not in the compel behavior of free citizens.
Senator Benson, did you have any other testifiers that wanted to speak to this bill?
I believe Mr. Huff from MDH is here. If he would like to comment, I am, as always, happy to take technical help and make sure that this can be implemented.
Mr. Huff, please state your name for the record.
Thank you, Mr. Chair, committee members. My name is Dan Huff. I'm an assistant commissioner with the Minnesota Department of Health. Thank you for inviting me to speak today. First of all, I would just like to outline a few of the things that MDH does not do. Or rather what we do. So we always follow the Minnesota Governmental Data Practices Act, which specifically calls out how we treat private health data, those data must be maintained as private data, and we never share those data. We're always very, very careful at MDH to never disclose any information that could be tied to an individual unless the public is so at risk. And there we always only have a commissioner order, and that can always be addressed in court if need be. Some of the things that we always do with our contact tracing, as that's been brought up a few times, whenever we call someone and ask them information, so we're calling someone about a case investigation, someone is infected, or maybe we call someone who is a contact. Before we ask for any information, we always provide a tennyson warning, just to let folks know that they do not have to provide us this information. It's completely voluntary, and to understand how we might use those data if they do provide that. Some of the other things is we do not compel people to be tested. We don't compel people to be vaccinated. We encourage it strongly because we feel, especially in our current pandemic and this public health emergency, the only way we're going to get through this and really open up businesses and let us return to normal is if the majority of the population does voluntarily get vaccinated. We know that the vaccines are safe and they're effective. So we definitely encourage and want to do everything we can to remove barriers so that people will get vaccinated, but we do not compel that. We do not force people to become vaccinated. There are a few parts of the bill that I would like to speak specifically to that I would say MDH has the most concern about. And it's really about the how long that we're able to keep data. So specifically, starting in line 2.22 of the bill, that's subdivision 3 under communicable disease reports, following on, so I guess it would be A and then B, that limits our ability to maintain our data on disease. So basic to how public health works and how our modern disease surveillance system works. And now this is a national system. Every state and American territory uses this system where there are particular reportable diseases. So tuberculosis, for example. If someone is infected with tuberculosis, that is reported to the state health department. We as the health department, again, we strictly adhere to not just the letter, but also the intent of the Minnesota Minnesota Government Data Privacy Act. But the reason we have those data is to work with that individual, to work with local public health departments to track that individual, and track is I don't want to use that as a government like we're watching a person, but rather we are working with that person to make sure that they're getting the treatment that they need. So I want to take tuberculosis as a first example. Tuberculosis, for a healthy individual who has a strain that responds great to treatment, can take 3 to 6 months to treat and get rid of the infection. For drug-resistant strains or someone that is immunocompromised in any way, it can take 2 years or longer to treat that infection and cure the person, as well as make sure that they're not able to communicate that disease to others. So having a 90-day limit would make it impossible for us to make sure that we are effectively supporting people in their treatment, as well as being able to contact trace if that person has come into contact with other folks and potentially spread the disease to them. Tuberculosis, when we first are exposed to tuberculosis, we can be asymptomatic for years, never even know that we're infected, that the bacterium is inside of us, and it waits until our body is run down, our immune system is run down until it attacks us, and then it can come over and it can be a severely debilitating and even deadly disease. That is why a 90-day limit would be so, it would basically render our ability to do public health intervention on tuberculosis non-existent. Let me give another example of hepatitis B. Hepatitis B is another community or a reportable disease. So we at MDH, we have in our database or secure database, if someone has hepatitis B. Well, if someone becomes pregnant, they have hepatitis B, they can pass that on to the baby when it is born. It's really important that the clinic that is delivering that baby, regardless of where the mother, if the mother was born in Hennepin County and moved to, another county, outstate or vice versa, or maybe was traveling and delivered somewhere else, has the ability to say, oh, this mother has hepatitis B. We need to make sure that the infant is treated with immunoglobulins right when they're born so that that infant does not contract hepatitis B from the mother. Hepatitis B can lead to lifelong complications. It causes severe liver disease. An infant just doesn't have the immune system to fight that off, which means that it is very likely that an infant without proper treatment would have severe lifelong complications and perhaps die early. So these are just some examples of, a pregnancy is more than 90 days. So a limitation in our ability to keep data limits our ability to then work with diseases because diseases do not have a 90-day time limit. It prevents our ability to go back. For example, right now we're dealing with variants with COVID. Some of the cases that we are now looking back at, we're saying, wow, was that a variant? Maybe we have a breakthrough with the vaccine. How do we know why did the vaccine fail if someone was infected or 90 days previous? We need to have those data so that we can track things over time, go back and look at someone's case history to see what happened, beyond that 90-day period. So that probably is our most.
We have a question. I'm going to go to Senator Benson.
Mr. Chair, Mr. Huff, but paragraph B says that if you're using it for investigation, and I would be happy to add treatment, that it doesn't have to be destroyed in 90 days, that it continues until the end of treatment. And I don't know why, when you're dealing with variants, you would have to go back to the individual and not just the fact that there was a test. I mean, we're starting to get into research space here then, and Minnesota has some pretty strict laws about participating in research. And so I differentiate retention of a viral sample to actual specific information for contact tracing. So I think paragraph B deals with some of your tuberculosis concerns. If we need to put treatment in, I'm absolutely on board with that. And when it comes to the tracking of specific variants, if those variants are retained and specifically identified and research is being conducted without the informed consent of the individual, we're going to have a whole different can of worms.
Mr. Huff.
Thank you, Mr. Chair. Senator Benson, this is not about research. This is about how do we effectively mount a public health response. So, for example, in the well-publicized Carver County cluster, and I just want to point out, this is not because of Carver County. This is because of the virus that infected a community of people who happen to live in this county. So I do not want to disparage in any way that county. This is about the virus that is extremely mutable. It is changing, and we now have these variants. What we are able to do is by looking back. So with this law, anyone that had been infected 91 days ago with COVID would be expunged from our record. The challenge is COVID's a brand new disease. We're still learning about it. We don't know about reinfection. Let's say we have a variant like P1, which we think may be reinfecting people. We now know that someone is infected. We do not have a record because they were infected over 91 days ago that this is actually a reinfection. That has incredible significance to our public health response. It's not about research. It's about understanding how do we respond to this disease. The same thing if someone, we have people that were case contacts from 90 days ago who had no other case contact. We would learn maybe the disease had been latent for that period of time. By limiting us to this artificial 90-day construct, it prevents us from understanding and learning about the disease. That understanding and learning is imperative for our ability to mount an effective public health response. And I just want to add that these data are private. We don't do, we don't share these data. These data are for us to understand and respond to a disease in order to protect the public.
Thank you, Assistant Commissioner. Members, any questions for the testifier or to Senator Benson? Senator Benson, any final thoughts or comments?
I am willing to work with Mr. Huff to remove provisions that he indicates would interfere with our understanding, particularly of COVID. I think that for known non-emergent viruses, infectious diseases, there should be a time limit, and the department should be transparent about what that is, and it should coincide with when the department no longer needs contact with the individual. And that should be something that is clear to the individual who's sharing that data. I know we have been dealing with TB outbreaks across the state in different places. There was a year when we had a number. We had so many, we actually had to create an emergency response fund in order to deal with them. So I understand that it's important, but there also needs to be a limit. So I'm willing to work with Mr. Huff on what those time limits could look like.
Thank you, Senator Benson. Members, we are going to vote to pass this out to civil law. So please turn on your cameras, your microphones, and Senator Benson, would you like to move your bill?
Mr. Chair, I move that Senate File 1589 as amended be recommended to pass and referred to the Committee on Civil Law and Data Practices.
All in favor, say aye.
Aye. Aye.
Opposed, nay?
Nay.
No.
Senate File 1589 is headed to civil law. Senator Benson, are we going to do Senate File 2247 up next?
Mr. Chair, while you were in judiciary, we passed our vehicle bill, and so we have completed our agenda.
Wonderful. Okay, so I'll give the gavel back to you, Senator Benson.
Thank you, members. We will be meeting after spring break to work on our budget, and Ms. Strand will notify you of meeting times during that week. Until then, I hope that you enjoy the break, refresh, and come back ready to sprint to the end. With that, members, we are adjourned.